talk really on. We're going to start with the basic science of cartilage. And cartilage is just a wonderful substance. It keeps us doing all the fun things we like to do when we're young and even when we're old if it keeps working. And when it goes bad, it punishes us and provides a tidy living for the orthopedic surgeon. We're going to talk about articular cartilage, hyaline cartilage. It's the material, 2 to 4 millimeters thick, slick, smooth, white cushion that we see at the end of the bones. It's avascular, aneural, alymphatic. It gets its nutrition from diffusion from the synovial fluid. Some words that we use to describe the cartilage: anisotropic, the properties vary with the direction of the force applied. It's biphasic. It has properties of both liquids and solids. It's viscoelastic. It's viscous. It means that it's like a thick fluid that resists flow, but it's elastic because it springs back to the same shape when the load is removed. Its function is to distribute the load. Proteoglycans resist compression, and they're pretty good at it. They can withstand impact loads of up to 25 newtons per millimeter squared. I was on a test one year. You have to remember it. It also is the bearing surface on the end of the bone and decreases the friction. The problem with cartilage is it heals poorly. Cartilage injuries don't heal at all, and if it's an osteochondral injury, it heals poorly with fibrocartilage. Well, what's this wonderful substance made of? Well, think of the planet Earth. 74% water, mostly water in cartilage. Proteins, the number one protein is collagen. Next followed is proteoglycans, and then chondrocytes, and then there's some other little things that no one really cares about. Water is the big substance that you need to know about. The fluid leaves the hydrophilic proteoglycans with the deformation of load and returns when the load is released. The water carries the nutrients back and forth and provides lubrication. The lubrication's buzzword is elastohydrodynamic, and it's really good at being lubricated. The coefficient of friction is better than metal on metal, better than oiled metal on metal, slicker than ice on ice. Human cartilage's coefficient of friction is 0.003. The main protein in cartilage is collagen. It provides the tensile strength, the stiffness. It forms a tight fibrillar meshwork, basically a net that traps all the proteoglycans. You remember from medical school there are 3 alpha pro-collagen chains that are wound together into a triple helix. The triple helix forms a collagen molecule. The collagen molecules are all lined up to form this banded pattern that we see on electron microscopy. Another cool thing about that alpha chain is it's made up of proline that is hydroxylated by vitamin C to cause hydroxyproline. That's from vitamin C. Scurvy. Collagen, types of cartilage. Type 2 is by far the main type of collagen in cartilage. It provides the bulk of the collagen, but there's some other things there too. Now, type 2 cartilage is the stuff that's also found in the nucleus pulposus of the discs. Type 1 is in the annulus fibrosus, and type 1 is in skins and bone. We'll talk a little bit about that. The other cartilage collagens are 9 and 11. They serve as linking proteins between the collagen 2 fibers. The final one, and the one that they seem to love to test on, is cartilage type 10. It's only near calcified cartilage. The calcified zone of articular cartilage down at the bottom and the hypertrophic zone of the growth plate. So if it makes things hard, it's rated X, number 10, mineralization and calcification. Collagen's so important that if it goes bad, bad things happen. If you're born without the ability to secrete collagen from your cells, it's called achondrogenesis 2, and you're dead. You don't live. But we're finding that most of what we consider now primary osteoarthritis may have a genetic cause and a predisposition. And the best one that they can start testing about now is familial precocious osteoarthrosis. And that's patients who have an altered type 2 collagen. There's some other ones that are less frequently tested on. Remember, type 1 collagen is bone. One bone. Type 1 abnormalities. For the bone, osteogenesis imperfecta, bone fragility, defect in type 1 cartilage. The rubber man, thick skin, since type 1 is also in skin, Ehlers-Danlos syndrome is a problem with type 1 collagen. The next big substance that's in cartilage are the proteoglycans. 95% of the proteoglycans are chondroitin and keratin sulfate. The sulfate ions are in red, and I think these things over here are molecules. But the bottom line is that they have these red sulfate things on them. Those red sulfate things are put together in long chains of the proteoglycans that repel each other and attract positive cations like sodium and calcium. All of those ions increase the osmotic pressure, which inflate the elastic meshwork and give it strength and compression. Here's your bristle brush. The hyaluronic acid chain is linked by a link protein, and then link has a K in it, and so does this keratin sulfate molecule. It's a little short keratin sulfate close to the link protein. Over on the C-terminal side, chondroitin sulfate lives. That's the bristle brush. When a bunch of these bristle brushes all get put together, it's called aggrecan, which is a megamolecule of matrix. It's a bunch of these monomers all attached to a long hyaluronic acid chain. It fills the interfibular space of the matrix to provide the structure. So the collagen is the net that holds all the gooey proteoglycans together that bring the water in. And that talks about how cartilage works. It's kind of like a spring and a sponge. When you're non-weight bearing, the proteoglycan charges repel like a spring and attract water into the tissue. It inflates the matrix sponge with joint fluid, provides the turgor, and it feeds the cartilage as the water moves in. When you step on the cartilage, the load squeezes the proteoglycan spring together and compresses fluid out of the sponge. And that makes the fluid available for lubrication and to gain nutrients from the synovial lining. Chondrocytes are the only cells in articular cartilage. They're lonely. Anaerobic metabolism, no blood vessels around to give them any big fluid, but they're very, very metabolically active. This cell is just as active as a gut lining cell or a skin cell. It just has to get its fluid or it gets nutrition from somewhere else. What's it doing with its metabolic system? Well, it's synthesizing matrix and maintaining the matrix structure. And if you look at the cell, what they do is it creates collagen and proteoglycans and spits them out of the cell, and then they're put together outside of the cell. And here's an electron microscope of a cell spitting out collagen and proteoglycan. And look, the further you get away from the cells, these cells are put together into the fibrillar collagen molecules and the proteoglycans. Again, procollagen is secreted from the cell and it's put together outside of the cell. And that's true of collagen, elastin fibers, and the hyaluronic and proteoglycan. So the molecular organization is very important, and we'll talk a little bit about this. There's a gliding zone on the surface that transitions down to the bone. And it depends on how you look at the molecules to what you see. On an H&E stain, you can see the collagen fibers here on the surface are thick, all of these lonely cartilage cells down to bone. A stain for proteoglycan shows that there's a lot of proteoglycan in the middle and just a little bit on the outside. On the surface, the collagen fibers are transversely oriented, and down toward the bottom, they're longitudinally oriented, one for shear and one for compression. And the cells change shape too because they're doing different functions. Briefly, the superficial cartilage layer, the tangential zone, is where the thin lamina splendens exists, and that's where the rubber hits the road in the cartilage. The cells are thin, the collagen is oriented tangential, and it's the highest concentration of collagen inside the cells because it's there to provide strength against shear. The chondrocytes are flat because they're making this collagen. It has the highest level of water because the synovial fluid is just on the other side of the lamina splendens, and it has the least proteoglycan concentration. The middle layers, they have oblique fibers. They have the largest collagen diameters. They're formed for strength and compression. They have the highest level of proteoglycans and the lowest level of water. And it's divided up into the transitional zone and the radial zone based on the collagen fibers. And you can see how the collagen fibers here are longitudinally oriented for strength in compression. There are plump chondrocytes with a high level of proteoglycan. They also have a low level of water. The final layer is down near the bone. It's the calcified cartilage zone. It starts at the tide mark. It's the transition to bone. Injuries that occur above this level don't heal at all. Injuries below here heal with fibrocartilage. Again, that's where the calcified cartilage is, and so the XXX type X10 cartilage is here. Cartilage injuries come in the Outerbridge classification and range from soft, fibrillated, cracked, to all the way to bone. When the cartilage is intact, the injury can be from a single severe impact or repetitive trauma. When it happens that it's a partial thickness tear, it will not heal. If it goes through the tide mark, it heals with fibrocartilage. Hunter said it way back in 1743s, but you guys sports medicine doctors don't get it. Ulcerated cartilage is a troublesome thing that's once destroyed is not repaired. we got to wonder about putting all those guys out on the football field because there's this progression that we see that gives us joint doctors something to do. Osteochondral failure, osteoarthritis is not the same thing as aging. In osteoarthritis, we're stimulating the degradative enzymes that are in the collagen cells, and that releases IL-1 and TNF and nitric oxide. It induces the synthesis of metaproteases that degrade the matrix. The matrix metaproteinases are also called collagenases, stromolysins, and gelatinases. And if you look at the picture, you can see this is normal cartilage. All these lonely cartilage cells just doing their job. But when osteoarthritis comes along, those cells start multiplying and trying to attempt to repair it, but it's an abortive attempt. Collagen cells are just not that good at doing it, and it leads to this terrible arthritis. Aging is not osteoarthritis. In aging, there is a lack of anabolic response, so that we don't respond as well. We can't make the cartilage work. You have decreased matrix production and decreased matrix maintenance. And you can see up here, newborn babies have long aggrecan molecules with many bristle brushes that look beautiful and healthy. Old people like me, we get less collagen, we have shorter molecules. We also notice that collagen content decreases with age. So, aging and osteoarthritis, not the same thing. Aging, when we look at it, it's a stable superficial fibrillation. Osteoarthritis, it's a fibrillation that's progressive and goes all the way until the cartilage fragments to bone. In the cells, there are decreased chondrocytes in aging, decreased synthesis, where in osteoarthritis, the cells actually multiply and there's an increased synthesis. The key thing is there's an increase in degradative enzymes with osteoarthritis, and in aging, there's a decrease in anabolic response. The water goes down with aging. The water goes up with osteoarthritis. The proteoglycan size goes down with aging and down with osteoarthritis. The bottom line, though, is the mechanical response is the same. They have decreased stiffness, decreased tensile strength in both aging and osteoarthritis. That leads us to the synovial fluid, the joint juice. There's usually not very much, about 2.5 cc's in a knee. It's clear, straw-colored, few white blood cells. It demonstrates non-Newtonian flow. That means that the viscosity changes as the shear rate changes. And in the joint, the viscosity decreases as the shear rate increases. Synovial fluid is an ultrafiltrative blood plasma which nourishes the cartilage cells via diffusion and acts as a lubricant. We have to talk a little bit more about lubricant, and we talked about elasto-hydrodynamic. It's a deformable surface. The surface changes shape, so it's elasto. It secretes the fluid, or you squeeze out that fluid, so it's hydro, and that's probably the best word if you had to pick one lubrication for cartilage, elasto-hydrodynamic. There are some other kinds of lubrication that you need to know about, and squeeze film, fluid film lubrication, is when the surfaces are separated by an incompressible fluid film. And the protein that they're going to want to know that's linked to that is hyaluronic acid. And then we inject an hyaluron for that reason. Now there's another kind of lubrication called boundary lubrication that goes on inside the knee. It's specialized molecules that attach to the surface that's being lubricated, and it permits surface-to-surface contact, but decreases the overall coefficient of friction. And the molecule to know about boundary lubrication is lubricin. It's a glycoprotein. You can tell a lot about what's going on inside your knee by looking at the fluid that you pull out, especially in monoarticular arthritis. And so if you get a single joint swelling, it's worth looking at the fluid. You order cell counts, crystals, and cultures. And you guys have seen this table before, but it's there if you want to see it. Now here's the joint synovial fluid parade, and you can see that normal fluid you can see through. If you can't see through it, it's probably pathologic. If it's just a little cloudy, maybe RA, maybe gout. If you see fat globules, well, it's a fracture. And if it's really, really grungy, it's probably pus. The synovial fluid crystal parade, the ones that you really got to know are those thin yellow crystals, gout, and the blue crystals, CPPD. They may throw you a steroid crystal or cholesterol crystal, but don't count on it. Remember UPAN, yellow, urate, parallel, negatively birefringent. Negatively birefringent means it's parallel to the compensator and it's yellow. CPPD is positively birefringent. Blue crystals when the axis is parallel to the compensator. And you can see the little crystals, and you've all been there in the arthroscopy where you've seen these crystals inside the cartilage. And sometimes, even on the x-ray, you can see these calcium crystals. And remember the link between hemochromatosis and crystalline disease. All right. I don't understand this. All right, the next one. You got to wonder if someone gives you the talk where you have to put your name next to perioperative problems. We're going to talk about a bunch of things that are not the classic orthopedic clinical progression. Most of the time we take unhappy patients and we make them very happy. Sometimes that doesn't happen, and some of the things we're going to talk about are lung problems like clots, ARDS, and fat embolism syndrome. And we're also going to talk about shock, malignant hyperthermia, and surgical nutrition because it has a lot to do with whether your wounds heal. Blood clots. Big problem in orthopedics. You all need to be experts. You probably know most of this. We're going to review it real quickly. A clot's a solid mass of blood or lymph. When it starts moving, it's called an embolism, for the Greek throwing in. Where the clot is very important. If the blood clot is down in the leg, as most of the clots around total knees are, it's probably not as big a deal. But when it gets close to the hip and you see the clot here, that's the real problem because it can go to the lung. DVT and PE rates in unprotected orthopedic surgery patients. Now, none of your patients are unprotected because it's such a big deal. But back in the day, in arthroplasty patients, in trauma patients, and in hip fracture patients, just about half of them got blood clots. Proximal clots, the big ones, are much more common around hip issues. Fatal blood clots in about 5 to 10% of hip fracture patients. Anything that you diagnose by a routine autopsy is bad to the bone. Unprotected arthroplasty. Total joints are a great laboratory to study blood clots because it's an elective procedure. You can get the consent and you can see what those patients are all about. And so there are lots of questions based on arthroplasty patients. If the question is, what has the highest rate of DVTs, it's total knee replacements. But almost all of those are distal. Hip fractures and hip replacements have proximal DVTs, PEs, and fatal PEs in 1 to 2% of them. So what are the risks of a blood clots? Why do we care? Well, there is this thing called post-thrombotic syndrome where you get a swollen leg, they get pain, swelling, varicosities. The skin may change colors, it may be indurated, there may be an ulcer, but the symptoms are delayed for years and so we don't see them that much. The larger the clot is, the more a problem this is, and it happens in about a third of the patients who get IVC filters. The real problem for you, the orthopedic surgeon, is the recurrent DVT issue because it increases the risk that you're going to have for the next operation. And by golly, we want to have those repeat customers. We want to do the other knee, so their rate's going to be higher for that next operation. We want to do a revision if they wear out, and that's going to be higher for the next operation. And if they have a hip fracture above their total knee, then we're really hosed. You don't want to kill your patients. You want to operate them over and over again. The real bugaboo is pulmonary embolisms. It's the most common death after total hip arthroplasty or total knee arthroplasty. It's the most common readmission after hip arthroplasty. So we don't want to do that. We want them out of the hospital after we operate on them. The risk factors, your patients, post-operative, post-trauma, they're immobile, they may be older, they may be fat, they may have had a previous blood clot before. Of course, if you have medical issues like heart trouble or malignancies, stroke and nephrotic syndrome, those all increase the rates of blood clot. Pregnancy, of course, having a big tumor over your IVC can certainly cause a blood clot. And shock, when your blood doesn't move, you can get a blood clot. Virchow is the father of pathology, and he described it a long, long time ago. The 3 things you need to know about: endothelial damage, hypercoagulability, and stasis. We'll go through these. This slide, the picture on the right, demonstrates a acrylic study where they took a cadaver and injected their vein with an acrylic. And you can see through my preferred approach, an anterior lateral approach, the vessel gets kinked. And that kinking can cause endothelial damage. It makes sense that if you're going to cut on someone, you're going to cause some damage. If you manipulate the limb, you're going to get damage. And what that does is expose the collagen. And here you can see all of these platelets are gangbanging this collagen thing, and they all are here just doing their thing, trying to prevent the clot. And what they do is they release the fibrinogen, which causes blood clots. They release ADP, thromboxane, and the calcium that's required to make blood clots. This is a poor platelet that's late to the party. He hasn't shot his wad yet, but you can see the granules here with all those things there. The next one is hypercoagulability. This can be from increased clotting factors from the clotting cascade, and you've all memorized this, so we won't go over it over and over again, or it can be from decreased anticoagulants. There are some people who have genetic risk factors for this problem. The most common one that you get tested on is factor V Leiden. It's very prevalent and it's a high-risk problem. And so they're hypercoagulable. The clotting cascade is released with trauma and concentrated with stasis, which is the next part of the triad. Stasis from immobility, from bed rest, or the tourniquet. This is a picture of a venogram during an operation. And you can see the dye stops because you've done a posterior approach and you've wrapped up that vein, and that's going to cause both the collagen exposure and stasis. This is an intraesophageal echocardiogram, and there's supposed to be a hole in your heart where the blood moves around. When the tourniquet goes down, almost every single total hip or total knee, you can see this shower of blood clot and fat that shows up, and that's probably what causes all those postoperative fevers for the joint patients. Now, if blood clots are important, how do you diagnose them? Well, you know that you can see a tender cord, you may have a palpable cord, they may have edema, they may have distended veins. In medical school, you learned about the Holman sign, which is painful dorsiflexion. The problem is, the exam is really no help to diagnose blood clots, and it's the wrong answer on the test, because 50% of patients who have venographically proven blood clots have no signs. And 50% of the patients who have one of those classic signs have no DVT by venogram. So the real diagnosis in most studies, and probably still on the test, is a venogram. It's the gold standard, and it's really the only test for distal, unless you work at a place that's got a real sharp radiologist and a good MRI, and there is something called an MRA, which may eventually overtake the venogram. Clinically in the community, since we don't really care too much about distal clots, we worry about proximal clots, and the ultrasound is the test that they're going to want to ask. You stick that ultrasound thing, it makes a pretty picture where the blood is going through the blood vessels, and if you push down, the vein should go away. If you push down and you see the same picture, then that's a blood clot. It's no good above the iliacs. It's not so good in the abdominal region, and so you got to have another way. If you're really suspecting a large blood clot, the test question will talk about how are you looking for an iliac clot. You want to look for an angiogram, a spiral CT, and if they offered you an MRA or an MRA, that would be okay. Diagnosing pulmonary embolisms is not too difficult. You don't need to buy the book on shortness of breath. You need to make sure that you look at patients who are high at risk. Your patients, orthopedic patients, are all at high risk. The signs and symptoms that are present in above 80% are chest pain, shortness of breath, and tachypnea. There are a bunch of other things that can happen. Yeah, you can have a cough and crackles, your heart rate may go up, you may have a fever, you may cough up blood, but that's usually late. You may have right heart failure, but that's late. The workup, labs aren't really too helpful. We can't even use the new cool test D-dimer because you've already cut on their hip or their knee, and so their dimer levels are already increased. The blood gas may show hypocapnia or respiratory alkalosis, but the PO2 could be normal on a blood gas. The EKG is primarily to rule out dysrhythmias and heart troubles, and the chest x-ray is usually normal early. You may get to see a test question where you see a plate-like atelectasis here or prominent hilus, and if you're really clever, you can see this thing called oligemia, where the blood vessels, you can see them over here, but you can't see them there. But the chest x-ray is usually normal. So the workup begins most classically with something called a VQ scan. The ventilation part of this nuclear medicine study shows good lungs. The perfusion study shows there's a hole, there's a problem. And that problem is best diagnosed, the gold standard on most tests still is the pulmonary angiography, where you can see that there's a filling defect inside the vessels to the lung. Now, the internal medicine journals and books have this great algorithm which has something called low probability, but that's not any of your patients. Your patients don't have low probability. All of your patients are high probability, and you should go straight to either the VQ scan, or nowadays it's becoming popular to get a spiral CT in the bigger hospitals, and that's a better answer if you have the choice. A spiral CT, and in Europe they do a chest ultrasound. But here's a CT pulmonary angiogram where you can see a blood clot inside one of the vessels. Here's another one. Here's another one. They're very, very good. An autopsy is probably not a good way to diagnose a pulmonary embolism for your patient. It's not the clinical orthopedic progression. How do you treat a blood clot once you see one? Anticoagulation is the answer. Acutely, we use heparin, and some people are starting to use Lovenox, and then transition to Coumadin for 3 to 6 months. Thrombolytics and embolectomies are a possible answer, but that's controversial, so they probably won't ask you that. So how do you prevent them? If these are so bad that we don't want to have them because you can't operate on the other knee, how do you prevent them? Well, there are a lot of perioperative considerations. Surgical technique. Operate quickly and be technically brilliant. Autologous donation helps thin the blood. And then regional anesthesia, and almost every study has shown decreased blood clots and PEs. But beware of regional anesthesia and anticoagulants. Here's a back patient of mine, a cancer patient who had metastatic disease to her hip, who we went in and we did a beautiful hip operation, and she, about 2 or 3 days after surgery, after getting some Lovenox, developed pain in both legs, and she couldn't use those legs anymore. Well, that's not why we operate on people. And we got an MRI, and it shows this terrible clot, and my spine colleague showed me how to remove a clot from her back. Beware of regional anesthesia and anticoagulants. There are other methods as well. Mechanical methods, early ambulation, moving your feet, elevating the foot of the bed are all popular. Graded compression stockings like my nurse colleagues like. Difficult to say that there's much value in combination, so it's usually not the right answer. CPM is always the wrong answer. It has no value for DVTs. You probably use intermittent pneumatic compression hose, and the best results are from thigh-high intraoperative hose, and it can decrease your proximal clot to about 5%. Hard to get sometimes the nurses to do it. The ultimate in mechanical prevention would be an IVC filter. Its indications are if you have a contraindication to anticoagulation, you've had a failure of anticoagulation, or you've got a complication of anticoagulation, either hemorrhage or thrombocytopenia. Sometimes they'll use them for large free-floating thrombi. Chemicals can be used to prevent clots as well. Aspirin is not the board answer. I don't care what they say in New York. I don't care what they say on the East Coast. Don't pick aspirin. You can pick warfarin. It's okay. Warfarin is rat poison. It blocks vitamin K carboxylation in the liver. It works on factors 2, 7, 9, 10, and protein C and S. It has a half-life of 2 days, so it's slow on, slow off. It's cheap. It's easily measured. You want your INR to be between 2 and 3. There is an antidote. Vitamin K, fresh frozen plasma. The downside is that there's multiple drug reactions, food reactions. It's hard to control. You got to monitor it. Most orthopedic surgeons don't have the patience. It works all over this clotting cascade, 2, 7, 9, and 10, and also protein C and S. Lots of studies on warfarin. We know it works. Decreases the PE rate to like 0.2%, a very tolerable bleeding complication rate. Notice that when you use it preoperatively, you have a higher incidence of bleeding rate, and that kind of makes sense. And that's the real downside to anticoagulation with chemicals, is the bleeding problems. If it bleeds into your gut or into your head or into your spine, it's considered a major bleeding problem. If it requires a reoperation, it's considered a major bleeding operation. Or if the bleeding index is higher than 2, it's major. Minor is any other clinical bleeding, and that's a complication that's bad to the bone. It brings up the cost-benefit ratio. And the studies that are done on this you guys are probably aware of, but blood clots, 50% of those patients unprotected, is a high-frequency event, about 50%. So that's the efficacy endpoint, and it's easy to study because it happens frequently. Bleeding is an infrequent event, less than 5% usually, and so it's very difficult to find a statistically significant increase in bleeding. And that's what all the companies love to talk about. And that brings up statistics, lies, damn lies, and statistics. To show a statistically significant 50% decrease in the rate of blood clots from 20 to 10%, you only need 500 patients. But if you're trying to show the difference in bleeds from 3 to 1.5%, you need 5,000 patients. And to show a difference in what we really care about, fatal PEs, you need 20 grand. Heparin's another chemical we use to prevent blood clots. It's an acidic mucopolysaccharide that stimulates antithrombin 3. It inactivates factors 10A and thrombin. Has a short half-life, rapid onset, but there's some adverse reactions that they like to test on, and those are platelet factor IV antibodies, which cause thrombocytopenia in about 10 or 20%. Severe results in 1 or 2%. There is an antidote for the bleeding problem, protamine sulfate, made from salmon sperm. Heparin in general surgery is used frequently, low dose or mini dose, but that's not good enough and not the right answer for orthopedic surgery. Adjusted dose is good enough, but the problem is the bleeding rate. Now here's the clotting cascade, and it's just to kind of show where these chemicals work in this big diagram. And you can see that heparin kind of works all over the place, and low molecular weight heparin works at the main place that heparin works, which is factor 10A and 2A, which is the thrombin. They took the heparin molecule, broke it up in a lot of little pieces, and called it low molecular weight heparin. And the reason they did this is because the shorter molecules have fewer platelet reactions. So there's less thrombocytopenia with low molecular weight heparin, and it has a longer half-life. It's very popular. It's as effective as warfarin, has a fast onset of action, sub-Q administration. You don't have to monitor it. Protamine sulfate works. But there is the concern is the increased bleeding risk, and so most people recommend waiting 12 to 24 hours after surgery or after spinal anesthesia. Decrease the dose if your patient's less than 100 pounds or if they have renal insufficiency. And some people suggest doing the BID American dose, 30 units twice a day as opposed to 40 once a day, which they use in Europe. It's still pretty expensive, and so we have to decide whether it's worth it. There's another medicine out there that's been around long enough that they might test mechanism of action. Fondaparinux, it's an indirect factor 10A inhibitor by binding antithrombin 3. It's a single-chain glycoprotein, pentasaccharide, 1, 2, 3, 4, 5, batch-to-batch consistency because it's synthetic, and so it doesn't have the platelet effects. It's given sub-Q, has a long half-life, which is good. You give it once a day, but there's not really a good antidote out there yet on the market. Pentasaccharide, shaped like the anti-3 binding site of heparin, and it irreversibly binds antithrombin 3 to the factors 10A. Helps prevent clots. Again, the basic scientists are really clever. They're coming after one protein in the system, and they're trying to address that one place to see if we can control blood clots better. A similar medicine like that is Hirudins, which is a direct thrombin inhibitor, so it works on thrombin. What's exciting about the Hirudins is that there's a PO version out there. It's made from the glands of the leech. There's no known antidote, and it's used to treat heparin-induced thrombocytopenia. But antibodies, since it's a protein, can develop with long-term therapy, and it just goes to show you that everything old is new again. Leeches. Works on one protein in the clotting cascade. So, mechanism of action, they love to ask these kinds of questions. Aspirins work on platelets. Coumadin works on 2, 7, 9, and 10 and protein CNS. Heparins and low molecular weight heparins reversibly bind 10 through antithrombin 3 and thrombin. And fondaparinux irreversibly gets antithrombin 3 to bind to 10. Hirudins, the direct thrombin inhibitors, well, they work directly on thrombin. Now, there's some cost issues that are worth knowing about in your HMOs. We'll all teach you as you get out into private practice that the most cost-effective outcome for a blood clot is a fatal PE. Non-fatal PEs and bleeding complications are both very expensive, so we got to decide whether we're investing in prevention or buying bleeding. Now, we used to, everyone in the world could do their own thing, and we didn't really care what the guys in California did because we're in Texas, and by golly, we're going to do the Texas thing. We don't care what the New York guys do. But nowadays, with evidence-based medicine, there are consensus guidelines that the lawyers and you doctors and your hospital administrators can have access to. We really didn't care too much about it when it was just the chest surgeons, but Cliff Caldwell is an orthopedic surgeon, and he's on the panel now, and he has weighed in. And evidence-based medicine, they grade the evidence. Grade 1 means there's a clear effect and an unequivocal risk-benefit ratio. Grade A data is from rigorous, randomized, controlled trials with reproducible results. And the consensus guidelines in the year 2004 are elective hips, elective knees. You want to give them 7 to 10 days of an anticoagulant after surgery. That can be warfarin at an appropriate dose, 2 to 3 INR. It can be low molecular weight heparin or fondaparinux. The same recommendations for hip fractures exist. It's a little bit lower grade, grade 1B, because there are just not that many trials. It's hard to study hip fractures. They recommend that every hospital develop a formal strategy. Aspirin is not the answer, and use anticoagulants with caution if you're using regional anesthesia. You may not see them, but those clots are there, and here's 2 of them. We're going to move on to ARDS, which is adult respiratory distress syndrome. It's when the lung fails by edema. The complement pathway is fired up by something, and that recruits white cells, free radicals, arachidonic acid, TNF, IL-1, IL-8, proteases, and it tears up the capillary membrane. And so the increased pulmonary capillary permeability lets water inside the lungs. And the pathologist may show you this slide of all this pink gooey stuff inside alveoli. Alveolar lung. There's supposed to be air there. Intravascular fluid and protein leak into the interstitium and alveoli, causing hypoxemia, pulmonary hypertension, right-sided heart failure, and death. Death is bad. You can't operate on that patient anymore. 50% mortality is bad to the bone. There's no bull. ARDS, many etiologies. Extrathoracic sepsis, blunt trauma, all the way down to aspiration pneumonia and infectious pneumonia. What we care about are the non-thoracic trauma patients. Fixing long bone fractures can decrease the risk of ARDS. ARDS is a nonspecific clinical presentation to tachypnea, dyspnea, hypoxemia, and reduced lung compliance. The chest x-ray shows this white-out appearance. There are all sorts of algorithms on how the ICU doctors want to take care of it. They all start with oxygen and identifying and treating the precipitating conditions. For orthopedics, there are two things: fractures and infections. After you identify those things, then you're going to treat them with oxygen, ventilation with positive end pressure, expiratory pressure, PEEP, and in supportive treatment, you want to prevent their blood clots, prevent their stress ulcers, and give them adequate surgical nutrition. One of the causes of ARDS is fat emboli syndrome, and they love to test on this because there's a classic clinical triad. It's a wonderful thing. You show an x-ray of a fracture, and you expect people to know that they have a petechial rash, neurologic symptoms, and a delayed pulmonary collapse, or ARDS. And that's after an asymptomatic interval. So the patient comes in and you're trying to figure out what the heck am I going to do with this terrible, ugly, nasty fracture, and they die 72 hours later. Pathognomonic finding is this petechial rash, all these little polka dots. It usually happens on the upper anterior aspect of the body because fat floats. They did a study where they put them on their side and the petechiae showed up on the side. So it happens chest, neck, upper arm, axilla, shoulder, conjunctiva. Neurologic symptoms when the fat emboli go through an atrial septal defect, go to your brain, and you see those same beautiful little petechiae in this patient's brain. It's bad if you have someone's brain to look at. Confusion, stupor, rigidity, convulsions, coma, after looking pretty good for a while. They get pulmonary symptoms, ARDS, when the fat goes to the lungs, and the pathologist may sneak this slide in for you where they show this beautiful fat globule inside the lung. These are alveoli. They got a white lung or a white CT called a snowstorm. A biphasic clinical picture. There's an asymptomatic interval. They come in with their fractures, and immediately the fat globules get scattered about your body. They are incompletely blocking and temporarily block different vessels. And then after 24 to 72 hours, the hydrolysis of fatty acids stimulate the complement system to fire up and cause the crash of ARDS. The treatment is don't let your long bones go to the dogs. Early long bone stabilization and treatment with ventilation with PEEP. We're going to talk a little bit about shock, and it's just shocking that an orthopedic surgeon is talking about shock. But shock is the cardiovascular collapse with hypotension followed by impaired tissue perfusion and cellular hypoxia. It can be cardiogenic, which means there's a failure of the pump, which means either there's a bad pump from an MI or an arrhythmia, or a blocked pump from a massive orthopedic PE. Hypovolemic shock means there's nothing to pump. You've bled the patient or they've had a burn. Septic shock, the chemicals from the bacterial toxin has released the pressure from all the blood vessels, and it's like they don't have enough blood to pump. And neurogenic shock is the loss of vascular tone from a spinal cord injury or rarely from an anesthetic-related accident. So hemorrhagic shock is a volume loss from a pelvic bleed. In orthopedics, it's a pelvic fracture that they're going to show you, and they're going to say decreased cardiac output, or the patient has a rapid pulse. The peripheral vascular resistance may be increased, though their blood pressure may actually be up, but they get venous constriction, so they're cold, clammy. It depends on how much blood you lose, what kind of shock you get. The categories. If up to 15%, you may maintain normal vital signs. Up to 30%, it may just cause an increased heart rate or decreased diastolic blood pressure. About 40%, you get decreased systolic blood pressure, low urine output, and mental status changes. So by the time you see those things, it's a lot of blood. And more than 40% can be life-threatening. You may see narrowed pulse pressure or an immeasurable diastolic pressure. What they're wanting you to know is you treat it with fluid replacement. Crystalloids, lactated ringers, the best initial replacement. You want to find some packed cross-matched RBCs to transfuse them. And some trauma centers actually just keep the O-positive universal donor blood down in the bay for the crazy people who come in broken. Assessing fluid replacement, famous test question, urine output, the best indicator of adequate replacement. Now, if replacement's inadequate, you may see a metabolic acidosis, and so they may ask you that, but urine output is the best indicator. Neurogenic shock, often from a high spinal cord injury, and usually you've got the clues of paralysis or loss of feeling. But if they give you an unconscious patient, like this one, and they go, yeah, it's got hypotension, and what's the deal? First off, you've got to get a decent x-ray, right? 1, 2, 3, 4, 5, 6, 7. Uh-oh, 7's the problem. He broke his neck. And that causes a loss of sympathetic tone, causes peripheral blood pooling, hypotension, but with bradycardia because of the sympathetic problems. They get bradycardia and low blood pressure. And this may be the one time you're allowed to use alpha-1 adrenergic agents, phenylepinephrine and ephedrine. Finally, septic shock, bacterial toxins. 70% of septic shock is caused by gram-negative endotoxins that are found in the cell walls. So you give them the antibiotic, the appropriate antibiotic, you kill the bug dies, those lipopolysaccharides are released, and that's what fires up the antigen system or the cytokines. Tumor necrosis factor, IL-1, IL-6, IL-8. It causes systemic vasodilation, hypotension, coagulation systems activated, so they get DIC, and then endothelial problems, ARDS. Septic shock has a 50% mortality rate. It's the #1 cause of ICU deaths, and for orthopedic surgeons, the #1 cause is necrotizing fasciitis. It's this terrible group A strep infection that makes this nasty toxin that spreads faster deep than superficial and causes the beautiful wounds that we love to take care of. Okay. Finally, malignant hyperthermia. This is an anesthetic issue, but they like to test it because it has something to do with muscle. It's a rare autosomal dominant disorder of skeletal muscle cell membrane. They've defined the defect is the ryanodine receptor that's part of the sarcoplasmic reticulum. They know the chromosome that it's on. They know the gene. It causes a free release of calcium ions. It's triggered by halothane or succinylcholine, and you can diagnose it by muscle biopsy, but most of the time it's diagnosed clinically. So again, there's this triad here of the terminal cisternae, the T-tubule, and the ryanodine receptors are located right there. And that's where the problem is. It causes an uncontrolled release of free calcium. It causes sustained muscle contractions. They get spasms and their muscles are just really cramping down. That cramping causes muscle damage that releases myoglobin and causes rhabdomyolysis or acute renal failure. The muscle cell also has a lot of potassium in it, and so that can cause dysrhythmias. The constant contraction of the muscle causes heat or a hypermetabolic state, and classically that was tested by an increase in the temperature. Nowadays, the test is the increasing end-tidal CO2 that's unexpected. That kind of leads you to the muscle fiber types, because there's two types that you know about. There's type 1, red, slow-twitch marathon muscles that have a sustained action and let you go the distance. They have a lot of oxidative enzymes, and so there needs to be blood vessels, so they're very anaerobic and have lots. They're very aerobic and have lots of mitochondria. Type 2 are the white muscle fibers, fast twitch, and theirs are for the sprinters. Sudden action, they're anaerobic, they don't need the oxygen so much. In malignant hyperthermia, those slow, red, marathon muscles are the ones that are contracting, and they just can't handle it because there's not enough oxygen to keep them going, because they have a lower capacity for anaerobic metabolism, type 1. And that's what it looks like on an EM when the muscle fibers fall apart and cause rhabdomyolysis that releases the myoglobin and the potassium. So the essentials for orthopedics in malignant hyperthermia is an unexplained rise in end-tidal CO2. That's the earliest sign. It's the most sensitive and most specific sign. Now, they talk about masseter muscle spasm, but that's because that's the only muscle the anesthesia doctor can see. Everything else is hidden. You may have an increased temperature on the test, but that's a classic late finding. There are some diseases that have a higher rate of malignant hyperthermia. Central core disease is a goofy kind of muscular dystrophy. The muscular dystrophies of Duchenne and Becker also have a high rate. Arthrogryposis and osteogenesis imperfecta also have a higher incidence. And if you'll notice, this is a pediatric, mostly male problem. The treatment is dantrolene. Decrease the intracellular calcium by stabilizing the sarcoplasmic reticulum. They'll ask you that. That's been on the test. You also want to do supportive, give them fluids, don't let them kill their kidneys, keep them breathing and keep them cool. Finally, we're going to talk a little bit about nutrition, and you're supposed to have 9 fruits or vegetables a day. Have y'all had yours? Malnutrition, common problem. 40% of orthopedic patients are malnourished. Healing requires energy, and if so you want to do a lot of work with your hands to heal people, and you don't want to use up all the healing energy in your hands, you want to know about nutrition. If you have a 1 degree increase in your fever, it's a 13% increase in your metabolic rate. A femur fracture, 25% increase. Multi-trauma or a systemic infection, 50% increase in your metabolic rate. We all know about the starving kids in Africa, but Our patients, our grandparents, our nursing home patients, 15% of community dwelling elderly are malnourished. 60% of the institutionalized are malnourished. And 65% of elderly in the acute care hospitals don't get enough nutrition. How do you measure it? Well, if the patient gives you a history of weight loss more than 10% in 6 months, that counts. If the test question's more than 5% over a month, that counts. Arm diameter is an easy thing to measure. Tricep skin fold is a very effective way to do it. But we don't do those. We use labs. If your lab's albumin shows less than 3.5, if you have a transferrin less than 200 milligrams, or a total lymphocyte count less than 1,500, then you are malnourished. Low values of these three lab works predict poor wound healing and infection, which is not what you want. Surgical site infections are decreased by adequate nutrition, measured by an albumin greater than 3, a total lymphocyte greater than 1,500. Glucose levels in the normal range. Keep the diabetics under control. Transcutaneous oxygen greater than 20 and ABI greater than 0.5. Preoperative warming of your patients a good idea and giving them lots of oxygen. Use monofilaments if you're afraid of infections. And get your patients to stop smoking because there's a huge rate of problems with wound healing in people who smoke. So that ends the perioperative problems. And I once went to a meeting where they said, don't ever become an expert in orthopedic infections or people will send you theirs. If you learn nothing else about orthopedic infections, remember Staph aureus. It's the question answer most of the time. Staph from bunch of grapes, granules, and aureus is from golden coins that show up on the Petri dish. Pus, what all orthopedic surgeons love to deal with. And we're going to talk about a lot of pus before we let you disappear. Soft tissue infections, we're going to talk about bite injuries, bone infections, joint infections, some other specialized infections, and a little bit about mechanism of actions for antibiotics that they like to test on. So first off, anything that cuts your skin puts you at risk for an infection. We're going to talk about three groups. Cellulitis and erysipelas, which are superficial things we don't care too much about. Some bad things, necrotizing fasciitis and gangrenes, and then some more on surgical site infections and toxic shock. Cellulitis is an infection of the subcutaneous tissue. Group A strep is the most common. Staph aureus is much less common. You treat it with Diclox PO or a first-generation cephalosporin. You may see redness and swelling. It may hurt. Admit them if the test talks about a high fever, if it talks about the patient looks toxic or septic, or poor host resistance. You want to admit them for IV. Erysipelas is also known as St. Anthony's fire because in the Middle Ages there was a terrible brand of strep that was running around and causing all of these plaques. It's a painful, well-demarcated plaque on the face or the extremities. It's caused by a group A beta hemolytic strep, strep pyogenes. These patients can become severely toxic if they're infants, diabetics, alcoholics, or elderly. The treatment for early cases, PO, Diclox. For late cases or severe problems, IV nafcillin. Necrotizing fasciitis, anything that goes by the moniker flesh-eating bacteria, anything that eats flesh is bad to the bone. This is a life-threatening fascial infection. It's the worst of the group A strep infections. Group A strep is the most common organism, but most of these infections are a mix of aerobic and anaerobic organisms. It can happen spontaneously, or it could follow a superficial strep skin infection like erysipelas. It can follow trauma, sharp or blunt, or surgery. So follow up your superficial skin infections and catch them before this gets out of hand. Much worse outcomes in diabetics, people with peripheral vascular disease, alcoholics, or IV drug abusers. The picture to look at is this picture. The blue discoloration of the skin, these giant bulli, are characteristic of flesh-eating bacteria necrotizing fasciitis. It's a rapidly progressing myonecrosis. It's liquefactive necrosis of the underlying fat. It spreads faster, deeper than superficial, so it's worse than it looks. 10 to 25% mortality rate. Systemic signs. Failure to respond to IV antibiotics should make you worried about your patients with infections. The treatment is emergent wide debridement and IV antibiotics with clindamycin, penicillin, and gentamicin. The other bad soft tissue infection is gas gangrene, and if they give you gas in the soft tissue in someone who hadn't been operated on, you got the diagnosis. It's caused by a gram-positive anaerobic rod, but usually these infections are also multiple organisms. Contaminated traumatic wounds shows up 6 hours to 5 days after the injury. Systemic symptoms are the clue because of this alpha exotoxin called lecithinase. They get painful, tense, swollen joint or extremities with pallor, and they may describe a foul, sweet-smelling discharge. And the kicker is x-rays that show gas in the soft tissue where you didn't operate. The treatment is surgical debridement. You want to open it up, let the oxygen in because the anaerobes can't take it. There are kinds of wounds that you should always leave open. War wounds must be left open. Lawnmower injuries must be left open. Tornado injuries must be left open. Because oxygen is so effective at killing the bugs, hyperbaric oxygen may help. Of course, you're going to use IV antibiotics, penicillin, clindamycin, and ceftriaxone. Surgical site infections never happen to me, of course, but when you have your surgical site infections, it usually takes about 5 days for them to present unless it's a streptococcal infection or a clostridial infection, which can show up in less than 24 hours. Remember the golden coins of Staph aureus, the grapes of Staph aureus, because that's the most common bug they test on for surgical site infections. Staph epi is also on the, or strep epi is also on the increase. MRSA is on the increase. So vancomycin is the drug of choice for MRSA. And over time, it's growing, it's causing a big issue. So you don't want to use vancomycin except when it's indicated, or you're going to have more problems that you can't take care of. There are 3 factors that involved surgical site infections: the local wound, the bacteria, and the host. You want to make sure you have good surgical technique. Operate quickly and be technically brilliant. Remove all the foreign objects. Debride the necrotic tissue. Prevent hematoma formation. Give prophylactic antibiotics anytime you're getting near the bone or doing a big, long operation. You want to make sure that you don't give it any longer than an hour before surgery. You want to repeat it if you're going to operate for longer than 4 hours. And if you're operating for longer than 4 hours, you ought to operate shorter. Repeat. Give them more antibiotics if your blood loss is less than 1,000 cc's. If it's a heavy patient, better than 80 kilograms, you may want to double your Ancef dose. Local environment, oxygen, warmth, tight glucose control. Shaving will increase your infection rate if you do it the night before. It's okay to do it the same day as surgery, right before you operate, but it may be better to use one of these fancy clip deals. The next is the host. You should think of patients you operate on or like you want to operate on. It's kind of like a sleeping relationship. People you want to keep coming back to see you and over. You've got to be very careful. Age, diabetes, and steroids all have higher rates of infections. The immunosuppressed have higher incidence of surgical site infections. Nutrition has a lot to do with infection rate. Smokers get more infections, and people who drink a lot get a lot of infections. Be careful who you operate on. They may come back over and over and over again. Bugs, the bugs have a lot to do with infection rate. The load, if there's more than 10,000 bacteria in a normal host, it will cause an infection. So 10 to the 5th, frequently a tested number for the bacterial load that causes an infection. So you want to use sterile technique. Dilution is the solution to pollution. Spacesuits, filtered air, and UV light are all helpful. The type of bug, the virulence factors that bugs control also have to do with infections, and some of them carry these plasmids that carry antibiotic resistance. Many bugs carry toxins like the gram-negative lipopolysaccharide endotoxin in the capsules of gram-negatives. Clostridium perfringens, we talked about the exotoxin A lecithinase. Strep pyogenes has an M protein superantigen, and Staph aureus can cause toxic shock syndrome, toxin 1 superantigen. And it's worth talking about that a little bit. You know, they came out with this great tampon. An orthopedic surgeon talking about tampons. A great tampon. It was so good that it even absorbed the worry. Well, that was a problem because these tampons would be colonized with this Staph aureus that makes this terrible toxin, which made a super antigen. It caused a toxemia, not a septicemia. So the fever, hypotension, and confusion was all caused by this goofy toxin. It caused a diffuse macular erythroderma, and then if the patient lived long enough, they would develop a desquamating rash. The wounds look misleading benign. It can be from just a surgical sponge could do this too. But the treatment, of course, is remove the tampon or the sponge, IND the wound, and give them penicillin-resistant antibiotics for staph, oxacillin, nafcillin, and fluid resuscitation. Now, this super toxin idea is kind of an interesting thing, and it's been around long enough that you may see it. It's found in both Staph aureus for this toxic shock syndrome toxin 1 or the M protein of strep pyogenes. Regular antigens that our body sees only stimulate about 1 in 10,000 T cells. The super antigens stimulate 1/5 of your T cells. And so there's this huge release of the complement system from the T lymphocyte toxemia where the cytokines are all released and it looks just like septic shock because it's the same kind of chemical problem. We're talking about toxins. We ought to talk about tetanus. Clostridium tetani is a gram-positive clubbed shape rod. If you showed that, you should be able to identify Clostridium tetani. They release a toxin. It's heat stable called tetanospasm. It blocks the inhibitory nerves and causes this miserable spasm that's been described in history and in the current literature. It's potentially lethal, and about 20 to 40% of patients die who get it. The treatment, of course, is prevention, and you can do that with good open wound care. Also, immunize your population. Tetanus toxoid, and since they're not going to get the Clostridium growing when they first hit, you want to make sure that the ER doctor in all of your trauma questions, and especially on your oral boards, if you have an open fracture, make sure you mention that we want to make sure that their tetanus is up to date. Late, you can treat them symptomatically with anti-tetanus IG, but it's not as good as prevention. Botulism also makes a toxin, and we don't think about it too much in orthopedics, but it's a gram-positive spore-forming rod, makes Botox, which is an endopeptidase exotoxin that blocks acetylcholinesterase release. If you eat it, it causes ptosis and a flaccid paralysis. And that usually comes from home canning of low-acid foods. In orthopedics, they're using Botox to treat dystonia and in the wives of orthopedic surgeons who are getting older. Infections bite. And now we're going to talk about bite infections. Human bite injuries are bad. Well, usually they'd be bad. Multiple organisms. All bites are multiple organisms, and Eikenella corrodens is the characteristic bug from a human bite. So make sure you know, Eikenella corrodens in a human bite, it's multiple organisms, you treat it with augmentin. Cats can bite, and the organism characteristic to cats and dogs is Pasteurella motacida, or Pasteurella septica, so a Pasteurella species, they may say. You also can get staph and strep, some gram-negatives, some anaerobes, multiple organisms, so you use augmentin or a third-generation cephalosporin. Dogs bite too. 50% of dog bites are mixed aerobic and anaerobic, an average of 5 organisms per dog bite. And Pasteurella motacida, the Pasteurella canis, Pasteurella species are common in cat and dog bites. Remember it, that's the test question. Multiple organisms, so you use augmentin or cefoxitin, a third-generation cephalosporin. Well, talking about dog bites, rabies, hydrophobia. It's an acute viral infection from a neurotropic virus in the saliva of rabid animals. Causes CNS irritation followed by paralysis and death. It is 100% fatal if you don't treat it before symptoms. So, you want to immunize high-risk workers and all your dogs. And if you find someone who you think's been bit by a rabid animal, you give them human rabies immunoglobulin, or HRIG. Now, the prophylaxis is to run. Don't get bit by a crazy animal. The animal differs by where you live. If you're in the United States, it's not dogs anymore because we're pretty effective at treating or giving them immunizations, unlike most of the children in our schools. Raccoons, skunks, and bats are the big reservoir in the United States. In South America and in Africa and Asia, the dog is still king. But look, there's also something else. In Europe, it's the fox and ruminants. You can get rabies from a cow. Things in the ocean bite as well. And marine injuries, and it doesn't have to be an animal bite, it can be a scrape, can be caused by Mycobacterium marinum. It's an atypical mycobacterium, an acid-fast bacilli, but it cultures in cool temperatures compared to the normal growth. So you've got to tell the lab if you suspect it, if you want them to grow it. It has a long incubation period, and it can cause from any injuries related to aquarium, freshwater, or saltwater. Mycobacterium marinum. This is what it looks like. It's a non-caseating granuloma. It's called fish tank granuloma or swimming pool granuloma or crab handler's granuloma or dock worker's granuloma. Deep infections get surgery and a long-term minocycline or clarithromycin because it's a slow-growing organism like TB. Bugs can bite too, and we talked a little about Lyme disease yesterday. The words to remember are Borrelia burgdorferi. It's a spirochete. Don't see many spirochetes in orthopedics, except for syphilis. Vector is the tick. Ioxodes ricinus, but it can be different kinds of Ioxodes bugs. Early, you see this characteristic bullseye lesion, and this is so testable, you just got to know. This bullseye lesion is erythema migrans. we don't usually see that in orthopedics. What we usually see are arthralgias. So about 60% of the untreated patients get this intermittent monoarthritis, where the knee's swollen, but it's not too painful, and you really can't figure it out. They don't have a meniscus tear, a chronic inflammatory arthritis. They may get sent to the rheumatologist, and they may be smart enough to diagnose it. It can cause meningitis, lethargy, headache. It can cause radicular neuropathy of Bell's palsy, and the treatment is long-term amoxicillin. Plants can bite too, and funguses grow on plants, and sporotrichosis is the most tested fungus. Sporothrix shinkai is the fungus that causes sporotrichosis. From rose grower's granuloma, rose picker's disease, from thorns and splinters. It starts out as a nodule that develops into an ulcer and can show lymphatic spread. If the pathologist gives you a slide, they may show you this beautiful little picture, which is an asteroid body. The treatment is debridement, amphotericin because it's a fungal infection, and potassium iodide. All right, we're done with soft tissue. We get into some things that are hard. We're going to talk about bone infections. And you got to be careful what gets inside your bones because sometimes it's hard to get rid of them. Osteomyelitis, the bone infection, used to be a miserable, terrible disease. 20% mortality rate in the year 1900. So much so that an open fraction frequently was initially treated with an amputation. There are two kinds that we think about. Exogenous, which is the most common type in adult, from open fractures, open wounds like diabetic feet, and postoperative problems that we cause ourselves. The other kind of osteomyelitis is from hematogenous spread, and it's most common in kids. It's from blood-borne organisms. They may have a positive blood cultures, and you see it in immunocompromised patients. Pediatric patients, they just don't have a developed immune system, and elderly, IV drug abusers, transplant patients, alcoholics, they all get it too. Acute hematogenous osteomyelitis, from bacteremia, more common in boys than girls, more common in the leg bones than the arm bones, common at the metaphysis because the blood vessels, the arteries come up here and the venules turn around and there's very slow flow here, and that's why pus shows up here. Patients present with pain, limp, loss of motion. You could use labs to help diagnose this one. You may see an increased white blood cell count, and you may see a left shift, but it may be normal. They often will have an increased SED rate, but the C-reactive protein is the test answer. The most sensitive test is C-reactive protein, and it's a good indicator of how your treatment is working as well. You may have a positive blood culture in 50% of the cases if you do it before you give them antibiotics. You want to diagnose it with an aspiration. You stick the needle into where that lesion is and pull out pus and grow it before you give them antibiotics. Now, talking about pulling the pus out, deep cultures are diagnostic. Don't culture the sinus tract. That's not the right answer to find which bug is causing the osteomyelitis. X-rays can show changes. Soft tissue swelling may be all that you'll see early because the demineralization may take 2 weeks to show up. Chronically, you may see something called the involucrum, which is the periosteal new bone around the site of the osteomyelitis. And a sequestra is this little piece of dead bone floating in a sea of pus. The radiologist has given you a great lecture for orthopedic surgeons. It is the most sensitive, and it's good for surgical location and finding pathology in the bone. A bone scan can also show you where the osteomyelitis is located and if it's multifocal. The treatment for osteomyelitis is first to identify the organism, and that's going to involve a needle or a knife, and that's what orthopedic surgeons do. If you don't have that information, Staph aureus, the golden coins, is a good test answer. Then, after you've identified the organism or tried to, you can use antibiotics. And for osteomyelitis, 6 weeks of IV antibiotic is going to be the answer. Outpatient antibiotics is okay if they're a reliable patient. Surgical debridement is going to be encouraged. You want to drain abscesses and remove dead tissue. Now, if you don't have a bug, you may use your empiric infectious disease skills by age. For adults and older children, Staph aureus. Infants, Staph aureus. NICU preemies, Staph aureus. There's not a whole lot of skill in there, is it? Remember, Staph aureus. Golden coins, groups of grapes, Staph aureus. Now, there's some weird things. Group B strep can show up in infants and some gram-negatives. And in the newborn period, 2 to 4 weeks, Group B strep may be the correct answer. So osteomyelitis, weird bugs, and who gets them? They used to test a lot on Haemophilus influenza. It seems to be less because it's a rarer infection secondary to immunization. But if they say you have a patient with Haemophilus influenza, know that the patient's probably between 6 months and 4 years of age and didn't get immunized. Pseudomonas is common in IV drug abusers and foot puncture wounds. Fungal infections, common in the chronically ill, people who've had long-term IV antibiotics, so there's
the only thing that can grow is a fungus, or parenteral nutrition because fungus can grow inside those containers. Salmonella is very common in sickle cell, and it's a weird diaphyseal sort of osteomyelitis. We talked about Mycobacterium marinum, water exposure, grow it in cold temperature, and group B. B is for baby streptococcus in newborn babies. Here's a newborn baby, neonate. They get Staph aureus, group B, strep, B for baby, gram negatives. Empiric therapy is nafcillin or gentamicin, nafcillin, and third generation cephalosporins to cover the gram negatives. Children less than 3 are like dogs. You can't talk to them very well, you can't figure out what's going on, and so they're more likely to have their osteomyelitis spread to a joint. And the hip and knee is the most common place. They are the ones who also can get the Haemophilus influenza, which is decreasing because of the rates of immunization that's going on now. You want to give these kids nafcillin and a third generation cephalosporin. Kids who are older than 3 can talk to you. They can communicate, and so they're less likely to have spread to the joint. The bug is Staph aureus, and the treatment is nafcillin, clindamycin, or just good old orthocillin Ancef. The treatment of hematogenic osteomyelitis, the adult bugs, Staph aureus and strep, cefazolin is the one that we like the best, but nafcillin, oxacillin, and vancomycin for MRSA can work. This is a beautiful picture. What do an egg, funny-looking red cells, and a turtle have in common? Salmonella is found in all of them. So, hematogenic osteomyelitis, sickle cell anemia, is caused by salmonella most of the time on the test. Salmonella is common in sickle cell. Salmonella is commonly tested. Staph aureus, however, is the most common cause of musculoskeletal infections in the sickle cell population. Sickle cell patients get microinfarcts of their gut and their bone. So you get dead bone and you get holes in your gut. So the bacteria can come in, and since they also have a spleen dysfunction, they can't beat the infection very well. And so they get this goofy infection of salmonella, and it's a diaphyseal involvement. And it's a very hard differential diagnosis between a bone crisis pain and infection of the bone. And so frequently you will have to stick a needle in it to aspirate it before you give them an antibiotic. And then give them the antibiotic, which will be a third generation cephalosporin or a ciprofloxacin. IV drug abusers, the bane of academic orthopedics, causes osteomyelitis, and it's frequently given as a test question for the medial clavicle. The bugs, the most common bug for IV drug abusers, think Pseudomonas, but Staph aureus and Staph epi are common. Empiric therapy for IV drug abuser with osteomyelitis would be Cipro and a penicillin-resistant penicillinase, or Cipro and Bank. A Brody's abscess is a goofy kind of osteomyelitis that's known as subacute osteomyelitis. It may have an insidious onset where they don't really have any trauma, but they got this goofy ankle pain or goofy knee pain. You discover a hole by x-ray and you're really worried about tumors. There may not be any systemic or local signs. They may have a little bit of a painful limp. Their SED rate may or may not be up. They may have a positive blood culture or they may be normal. You want to rule out a tumor because you just can't miss those. But the epiphyseal osteomyelitis and most Brody's abscess are caused by Staph aureus. Chronic osteomyelitis is usually from poorly treated trauma, poorly treated acute osteomyelitis, or an immunocompromised patient. The hallmark of chronic osteomyelitis is dead bone in compromised, scarred, soft tissue. A sinus tract makes the diagnosis for chronic osteomyelitis. And the treatment, again, is based on deep cultures, not the sinus tract. The x-rays will show sclerotic avascular bone. Remember, dead bone in compromised scar tissue is the hallmark of chronic osteomyelitis. So the pathologist is going to show you a slide with fibrosis of the marrow space with chronic inflammatory cells, chronic osteomyelitis. The other thing to know about is Marjolin's ulcer. This is a squamous cell cancer due to chronic inflammation and shows up in 1% of patients with chronic osteomyelitis. It can also, you can see it in burn patients and venous stasis ulcers and bed sores. You biopsy the edge of the lesion, do a wide excision and skin graft. Moving from bones, we're going to go to joints. Septic arthritis, usually from hematogenic spread or an extension from the pediatric metaphyseal osteomyelitis from hematogenic spread. Places where there is an intra-articular physis are more common, and the hip is by far the most common. The little kid trying to hold his hip extended, so he just hurts so much he can't move it. He's got this pus in his hip that needs to be drained. Proximal humerus counts, radial neck, and distal fibula all are intra-articular physis. The diagnosis, clinically, they have pain with motion, pain with loading. They may have effusion and warmth, and aspiration is the best test. You got to stick a needle in it before you give them antibiotics. The cells will be elevated, they may have a left shift, and can be mistaken for crystals, but you can have both crystals and pus. The treatment is to get the pus out. I&D is always a good answer on the test. For hip, knee, and shoulders, probably the best answer. The serial aspiration is probably an okay answer if it's an easily tapped joint. And then you want to give them an IV antibiotic based on your cultures. The organisms that we see by age, Staph aureus, Staph aureus, Staph aureus, Staph aureus, except for this one thing here. You guys, healthy young adults, don't get it Staph aureus as the most common cause of their septic arthritis. You guys get gonorrhea. So weird testable organisms. Lupus and sickle cell patients get salmonella. Migratory septic joints in your population, healthy young people, gonococcus. Now, total hips and total knees, they get Staph epidermidis. This is Staph epi. She loves that hardware. And Staph aureus. This is you guys right here. This is one of the guys from the San Antonio program I saw last night. He asked me what his problem was, and I said, that's not the bone doctor I am. Most common septic arthritis in healthy, sexually active young adults is gonococcal. It causes a migratory polyarthritis in 80% of the population. It's wrist and knee. The most common in girls around the time of their periods. Pustular rash shows up. Neisseria gonorrhea is the organism. And the pathologist is going to show you this slide right here. Gram-negative intracellular cocci. The empiric treatment is ceftriaxone. There are some special circumstance infections that we're going to kind of end with in the infection talk. Puncture wounds, diabetic foot wounds, because you didn't get enough foot yesterday, and the paronychia. Puncture wounds of the foot. Nail through the sole of the tennis shoe, osteomyelitis in 1 to 2% of the kids who get this. Pseudomonas is the most characteristic organism because it likes synthetic fabric and rubber as well as cartilage. Often they'll recommend that we core the wound, I&D it, take the cloth and rubber out, and use a third-generation cephalosporin or ciprofloxacin. Diabetic foot infections, this is a superficial view. I'm sure the guy yesterday covered it in much greater depth, but this is the stuff to remember. Skin coverage is the issue from neuropathy. Atherosclerosis makes it hard to heal, and if they get an infection, you got to remove it because it's just so hard for them to beat it. Diabetes, there's an excess glucose amount. It reduces the nerve function and leads to a neuroarthropathy and loss of protective sensation. There's autonomic dysfunction, and that causes this dependent rubor. When you hold their leg down, it gets red. When you lift their leg up, it gets white. Cellulitis doesn't do that. The problem is that they lose their ability to feel where their joints are in space, and they get this goofy kinds of problems with their joints and unrecognized skin trauma. Charcot arthropathy is the king of the unrecognized trauma. It causes deformation of the bone, abnormal mechanics, with higher pressures and a higher risk for ulcers. They get this goofy atherosclerotic disease called Muckenberg sclerosis, this thin fibrillar picture of sclerosis, which is in the muscular layer of the arterioles. The ischemia leads to decreased oxygen in the tissue. Low oxygen in the tissue is bad for wound healing, causes ischemic necrosis, and poor wound healing. Transcutaneous oxygen pressures less than 20 have trouble healing. Because fibroblasts can't make collagen without oxygen. White cells can't kill bacteria without oxygen. Finally, infections, the osteomyelitis, foot infections, and diabetes make it a permanent problem. Foot ulcers only have high numbers of bacteria if they're necrotic and they haven't been addressed. Again, more than 10,000 cells of bacteria per gram leads to poor tissue healing because they're releasing chemicals to keep your body from doing its job. Dead bone, the reservoir to hide bugs. You must debride the ulcers, debride to tissue, and remove the dead bone. Great algorithm over here. If you can stick a probe inside the bone and touch bone, it is osteomyelitis. You don't have to order an MRI. So the depth ischemia classification is in all the Academy publications. The depth classification, it ranges from no lesion, which is an at-risk foot, down to extensive ulcerations and abscesses where you want to consider amputation. The ischemic classification is non-ischemic to anything where there is some ischemia or gangrene. Vascular consult is recommended with any of those, so it's either not ischemic or it gets a vascular consult. So here's the stocking and glove neuropathy of an at-risk diabetic foot. There's no ulcer, but he can't feel a 507 Sines-Weinstein monofilament. If they can feel it, then 90% won't get an ulcer. No ulcer, but the patient's at risk. You want to talk about accommodative footwear, daily feet inspections, nail care, white socks, and sugar control. When they get a superficial ulcer, you can't touch the bone. The most common bugs are the gram-positive cocci. You want to give them empiric therapy of clindamycin or Anseth, and make sure they're using offloading devices, either a total contact cast, specialized shoes, or specialized braces, and your ulcer will heal. Deep ulcers, when tendons, or joints are exposed, or if you can reach in with your probe and touch bone, then it's osteomyelitis, and the bone has set up shop because it's chronic osteomyelitis. You need to debride the dead tissue, debride the dead bones, so that you can get rid of those bugs that are keeping the body from healing. Unroof the ulcer. If it's viable but neuropathic, you can keep it. If it's necrotic or ischemic, get a vascular consult. You're going to have to cut it off. Total contact cast diabetic shoes. If there's an extensive ulcer or an abscess, a foot here where it's a miserable gangrene and other things are happening, foul smell, then the infection is polymicrobial. It does have the aerobic gram-positive cocci, but it also has got Pseudomonas E. coli and maybe Clostridium. This is the patient who needs an open amputation and an IND. The empiric treatment is ticarcillin and gin or clindamycin and ciprofloxacin. The vascular surgeon consult, if they have any hint of ischemia, for ischemic pain, for a recurrent ulcer, or for a non-healing ulcer, or gangrene, get the vascular surgeons to peek at them. And what are they going to do? They're going to do things that are going to show you whether there's an indicator for poor healing. ABI less than 0.45, toe pressures less than 30 millimeters of mercury, a transcutaneous oxygen tension of less than 20. What is the vascular guy going to do? He's going to bypass it, he's going to balloon it, or he's going to stent it. The paronychia trilogy is where we're going. Acute paronychias, chronic paronychias, and herpetic Whitlow, which is really a viral paronychia. Acute paronychia is from Staph aureus. It's a single finger with pus. Trauma due to nail biting or hangnails or manicuring. Staph aureus is the most common organism. Strep, Pseudomonas, and anaerobes can happen. You treat this with warm soaks, clindamycin, augmentin, spontaneous drainage, or stick a knife in it and drain it. Chronic paronychia is multiple fingers and caused by Candida albicans. Boggy, tender, and red, but rarely fluctuant. This happens in people who work with water. Dishwashers, laundry workers, bartenders. Candida is the organism, and it may look like staph, but if you look carefully, there's these little buds that show up, and that means it's a fungus. And so you want to avoid the waters that fungus likes. You want to use antifungal agents like miconazole. You can use topical steroids on this one, and surgery is a last resort. Herpetic Whitlow is this ugly picture. It happens in dentists and anesthesiologists, people who have fingers in other people's mouths. It causes grouped vesicles with an erythematous base, clear fluid in the vesicles. The gram stain will be negative, but you may have a positive zinc test. You treat it with antivirals. Don't IND it. It won't make it get better quicker. We're not only at risk at causing infections, but our jobs put us at risk at getting infections. HIV is there, homosexual males, heterosexual increases occurring, hemophiliacs, IV drug abusers, patients from Haiti and Africa, all are high-risk HIV patients. Virus decreases the number of your T helper cells, and it causes an increased risk for wound and non-wound infections. To make the diagnosis of AIDS, and this was on my boards, HIV positive and opportunistic infections, or HIV positive and a CD4 T count less than 200. So less than 200 or an infection plus being HIV positive. What community you work in has a great deal with what kind of HIV you're going to see. In sub-Saharan Africa, 30% of the population is HIV positive. That's just scary. In Haitian, 6% of the population, unless you're a sex worker, then it's 65% HIV positive. Gay men in the United States at sexually transmitted disease clinic, it's 20% of the population. For heterosexuals at the same clinic, it's only 2%. Baltimore did a study in their emergency rooms, and they checked all the people with sharp trauma. 13% of the population was HIV positive. Got to be scared out there at Hopkins, guys. Think about it. Military applicants, very, very low rate of HIV. That's because most of these guys are hicks from small countries small rural areas in the United States, not likely to get HIV. The risks of transmission are fairly small, 0.3%. The risks are higher with a hollow needle, if there's blood on the needle that you're sure there was blood on the needle, or if the patient had advanced AIDS because there's an increased viral titer in their blood. Prophylactic drugs may help decrease the transmission if you have a stick with an HIV patient. So most of the hospitals have a very structured program with needle sticks. Follow it, because the risks are bad to the bone when you start gambling. Transfusion risks in the United States is 1.5 million units per unit, 1 in 500,000. And for the sports guys who are using this processed allograft, it's 1 in 1.5 million, which isn't that common, but it's better odds than the lottery. HIV risks in practice, they studied a bunch of us at the Academy meeting one year. Everybody volunteered to be tested. Well, not everybody, only half. 50% had operated on an HIV positive patient. 87% had had blood contact on their hands through the gloves within the last month. 2 tested positive, and both had something described as non-occupational risk factors. I suppose that means they worked in Haiti. Maybe. Hepatitis B, much more severe problem if you're not immunized, because a single stick transmission is 30%. Sexually transmitted, and you can get it from those human bites, so look out. Occupational blood exposure is what we worry about, and so we strongly encourage all medical workers to get vaccination because it works. It leads to liver failure, cirrhosis, hepatocellular carcinoma is a real problem. You guys remember that hepatitis A is really a fecal oral thing, and it's not a surgical problem, really. Hepatitis C, however, which used to be non-A, non-B hepatitis, has an intermediate risk, a single stick transmission of about 3%. It was the most common cause of transfusion-associated hepatitis until they got the test for it. It's prevalent in about 2% of the U.S. population. Egyptians, because they used to share their needles to give blood when they were transfusing, have about a 10 to 30% risk. And Japanese and Taiwanese who participate in the needle acupuncture stuff, there's a high risk of non-A, non-B hepatitis. It causes cirrhosis and hepatocellular carcinoma. There was one study that showed that 2/3 of U.S. patients that are newly diagnosed had a history of IV drug abuse, so beware. 2% of the population gets it from occupational exposure. Sexual transmission is not a major factor. We're going to end up with some antibiotic discussion, mostly mechanism of action. You know that antibiotics has really changed the world and made orthopedic surgery possible to do the wonderful things that we do. Before then, we cut off legs. Now we get to replace joints and watch people try and replace ligaments. Prophylactic treatment causes open fractures, prevents postoperative pus, but you got to use it within an hour before you put your knife to the skin. Remember, give extra medicine if it's a long case, if you have a lot of blood loss, or double your medicine if the patient's really a porker. Give more if they're a porker. Antibiotics used for all open fractures, grade 1 through grade 3B. But grade 3B, because they're exposures to a lot of the Clostridium, you add penicillin and aminoglycosides for all large wounds. 24 hours of antibiotics is as effective as 5 days for the routine open fracture that you wash up and close loosely. For complicated open fractures, continue the antibiotics for 48 hours after the wound's closure. How they work. Beta-lactam antibiotics, penicillin and cephalosporins, their mechanism of action is to inhibit the bacterial peptidoglycan synthesis. What makes gram-positive organisms positive is this layer of goofy cell wall. And if you can prevent that from forming, the bacteria won't live. And that's what beta-lactams do. Glycopeptides, vancomycin is a glycopeptide, works exactly the same way. It inhibits bacterial peptidoglycan cell wall synthesis. Remember that MRSA is increasing, and so we don't want to use vancomycin for everyone, just the high-risk people. Aminoglycosides, gentamicin, tobramycin, inhibit protein synthesis by working on the small ribosome. Think of amino as minor, a minor glycoside. A minor glycoside, the smaller ribosome. Because macrolides work on the large ribosome. Clindamycin, erythromycin, their mechanism of action is to inhibit protein synthesis by inhibiting the dissociation of tRNA from the reversible binding on the large 50S ribosome, macro 50S. Clindamycin is important for orthopedic surgeons because it has the best penetration of any antibiotic into bone. Tetracycline, the one with 4 rings, tetracycline, works to block the tRNA binding site on the ribosome. It also inhibits protein synthesis. You can't give it in kids because it stains their teeth. It gets permanently placed into bone, and so it's used for many studies there. Rifampin, mechanism of action, it's R, rifampin, inhibits the bacterial RNA synthesis, binds the DNA-dependent RNA polymerase. So RNA polymerase blocks RNA synthesis. R is rifampin. Quinolones are just crazy. These are spirally crazy things, and they inhibit DNA gyrase, which is an enzyme that helps spin the DNA to reproduce. So ciprofloxacin and levofloxacin, the mechanism of action is gyrase. So the buzzwords: penicillin, cephalosporins, vancomycin, all cell wall inhibitors. Aminoglycoside, protein synthesis, 30S. Clindamycin, erythromycin, macrolides, it's the large ribosome unit, 50S. Tetracycline has a T, and it inhibits protein synthesis by working on the tRNA. Rifampin has an R, it's a RNA synthesis polymerase, and ciprofloxacin and quinolines are the DNA gyrase. The Orthopaedic Academy and the American Dental Association got together to try and come up with an evidence-based guideline on who needs to be prophylaxed after you get a knee or a hip replacement. And they decided that all joint patients, both hip and knee, all patients for the first 2 years postoperatively should be prophylaxed for high-risk dental procedures. Immunocompromised patients, RA, lupus, HIV, transplants, maybe obese, maybe diabetics, should have it forever when they have a high-risk dental procedure. And the drugs, cefazolin, 2-ops, or any of the cephalosporins or amoxicillin, 2 grams 1 hour before, or if you're allergic to penicillin, use clindamycin. Clindamycin is the one that has good bony penetration, 1 hour before. There are tons and tons of test questions. You have them all in your handout. How are we doing on time?
Good.
We're done.
Here's what you need to do. You need to go through the answers, because somebody's going to have to hit all the answers. So just walk through the answers. We don't have to.
Well, it'll probably be easier just to give you a handout. The answer should be at the end of all the ones that have long ones. For the short, there's a couple of the talks that have just a few questions that are kind of weird that were hard to fit in, and so I gave you those questions, but the answers aren't very, very hard, and if you really want the specific answers, we'll make a handout for you, because we're not going to go through them all right now. Now, y'all have the answers to this one. The last slide has a bunch of numbers on them. If you look at your handouts, the bottom page has a number, and for every slide number, there's a corresponding answer as the very final slide for the infection one, which is really the longest one. You follow me? All right. I appreciate your kind attention during this very difficult lecture. I wish you all the best on your boards. Study your stuff, and you'll do well.